All right. Hey, everyone. Welcome to the OptiSpan podcast. My guest today is Dr. Jon Berner, MD, PhD. Jon is a board-certified psychiatrist who specializes in bipolar and psychotic illnesses, complex pain, addiction, and undiagnosed neuropsychiatric disorders. In this installment, we talk quite a bit about some really interesting case reports involving combined use of rapamycin and ketamine. We get a little bit into the role of inflammation and brain inflammation in this process, and in particular, speculate a bit about how microglia might be involved. I'm actually pretty enthusiastic and excited about the potential of these two drugs to have pretty big impacts on severe cases of depression and chronic pain. Really fascinating discussion, and I hope you enjoy it as much as I did. Okay, let's talk about rapamycin. It's come up, in passing a couple of times. I know you've got an interest and have used rapamycin in your practice. So maybe tell us a little bit about how you got going down that path. And our audience, if they've watched the OptiSpan podcast, they've heard about rapamycin. So I don't think we have to give much of an introduction to the drug.
I'm gonna give a little kind of narrative here.
Okay.
So as a psychiatrist, what I'm interested in is not nutrient switching in terms of starvation. What I'm interested in is tissue repair. Okay. And you can think of the nerve cells in your brain as being a little forest that grows through seasons of growth and repair. And that seasonality happens within 24 hours, right? So when you wake up, you have a highly edited hard drive with small nerve cells and small synapses. And as you learn things throughout the day, the blood flow through to your brain goes up by 30% because you literally have more tissue that is supporting what you've learned during the day. Then you go to sleep, and the microglia in the brain come out to feed. And their job is to digest the dead leaves and the broken branches and edit your hard drive and give you that deep, restful sleep so that you wake up in the morning and you're not quite the same person. And we all have this experience. I'm a little bit different today than I was yesterday. And that's true by definition because some of your memory span has been digested. And that's what allows you to solve this stability-plasticity dilemma, which is, how do I stay open to learn new things and yet hold on to the important experiences in my life? I would love this podcast to be a love letter to the people with NVIDIA and OpenAI and all of the people who are working on these large language models, because I've been working on this for 25 years, right? And the stuff you're doing is the stuff we've been thinking about very hard in terms of how do we solve this stability-plasticity dilemma. And the core player in this are the microglia. And we are massively involved in tissue repair every moment of our life, right? And so what rapamycin and ketamine, these two drugs that I'm using more and more in my practice, are doing is they're influencing the way in which we repair normative damage with age. This is like entirely in the aging community.
Yeah.
Right?
Yeah.
And so again, I'm going to get technical really fast, and I hope the people will forgive me, but you will know what I'm talking about.
We've got a pretty smart audience.
Good.
I think they'll get it.
Good. So let's look at the NDEFS model. Okay, so I have a bunch of your students. They all trained on NDEFS.
So NDEFS is a mouse model
of mitochondrial dysfunction.
Complex 1 specifically deficiency.
Complex 1 dysfunction.
Yeah.
Right. And it's looking like we can understand how these mice get sick because if you block colony stimulating factor 1 receptors in these mice, they don't die.
Yeah. And worth just mentioning, so one of the interesting things about this mouse model is even though it is a complex 1 of the electron transport chain, not quite null, but pretty close mouse everywhere in the body. If you fix that in the brain, you pretty much fix the disease.
Yeah.
This is really a brain disease.
Oh, it's even worse. It's even worse. It's if you only have it in glutamatergic excitatory synapses,
right.
You still get the full
you
disease.
Recapitulate the disease. That's
which
right.
goes back to this concept of hold my beer, Peter.
Yeah.
Which is, the brain, the hardest working portion energetically in the body are the presynaptic glutamatergic nerve terminals.
Right. I think this is worth just double clicking on for a second though, because this is one of those results that prior to doing that experiment, I don't think anybody in the world would have predicted that.
Yeah.
That you could knock out complex 1, the mitochondria, everywhere in the body, right? And you get this very, very rapid onset disease. The mice, it's a childhood disorder in people, pediatric disorder, and the mice are, dead by typically 60 days, right?
Right.
And if you only do that in this small subset of neurons, you get exactly the same disease.
It's amazing, isn't it?
And if you fix it in that subset of neurons, you basically fix the disease, even though you're deficient in complex 1 everywhere else in the body. Like nobody would have expected that last result until you do the experiment, which just, I think, should be humbling to everybody who thinks they know anything about biology, because that flies in the face, I think, of what we all thought we knew about how important complex 1 of the mitochondria is.
Well, I mean, this is where, my professional pride, kind of gets involved. It is so hard to create a brain that is able to do these beautiful things that we're doing, right? And the weak point is the mitochondrial metabolism in the presynaptic glutamatergic terminal. I mean, I think that's what NDUS really taught us. This is a hard energetic problem.
Right. Energetically, yes, absolutely.
Yeah. So anyway, if you knock out CSF colony stimulating factor 1, which is one of the growth factors for the microglia in the brain, these nerve cells don't die. I mean, these mice look pretty good.
Yeah.
Right. But you go downstream and you're like, what drugs are working in affecting microglia integrity?
And so just to give people context, what is the connection between CSF1 and microglia for this experiment?
Okay. Oh gosh, I'm going to try to break it down here.
Yep.
Okay. So when we're 4 weeks old in the embryo, there's a great migration. Like the wildebeest, or the geese in the winter, where primitive macrophages leave the yolk sac and they migrate into the brain and they form a resident population. So we have a bone marrow in our brain that's distinct from what's in our bones. And that bone marrow does not contain T cells or B cells, the cells that do antibodies or, specific viral or cancer immunity. These are resident macrophages. And, macro means big and phage means eat.
Right.
They're big eaters, right? And their job is tissue repair, okay? And they're not repairing nerve cells, because remember, nerve cells are post-mitotic. We don't really grow very many new nerve cells. What they repair are the synaptic arbor, the dendrites in the brain that are our hard drive that are holding information. Okay, and what do they need to repair? Well, what's actually being used a lot? Probably the mitochondria, I would assume.
Mm-hmm.
Okay, that's a hypothesis. I don't know if that's true, but I suspect that that's true. And so what they're doing is they're getting signals. They send out these long branches, these processes that probe like little fingers among the dendritic tree, and they're looking for synapses that are not doing well, that are sending out ADP, purine molecules, ADP, ATP, that are saying, hey, I'm in a lot of trouble here. And that ATP is a growth factor that stimulates these microglia to grow and to make more, saying, hey, we got a lot of repair going on here. And so I think what's happening in the NDUF model is these NDUF microglia are getting massive growth signals from damaged mitochondria
mm-hmm. Yep.
in the postsynaptic excitatory terminals. and it's inducing these microglia to divide and grow. Okay, but they don't divide and grow normally. They get stuck in something called an M1 state versus the M2 state. Okay, and I'll get into that in a second. So the M1 state is the inflammatory state, and the M2 state is the reparative state. And so all of these damage signals that are coming out of these damaged post-excitatory nerve cells are causing this massive growth of microglia in the brain. And they come out like Athena out of Zeus's head angry, right? They don't come out normal. They don't come out as stem cells.
Right.
They come out as angry, inflamed cells.
Right.
And now you have sort of this concept of, chronic senescence. I mean, nothing is working right. It's just all inflammation.
Right.
Okay. So when you use chemicals, drugs that are FDA approved, like ketamine and rapamycin, you affect specifically these microglia in the brain, and you force them into an equilibrium state where they're more in the reparative mode.
Right.
We have very good data on this that's coming out, and it's just so impressive.
And I mean, so I want to go back to CSF1 because that's kind of how we got started, and then we kind of wove our way. But I mean, one of the things with rapamycin that, was very surprising at the time was that we could rescue these NDUFS mice with rapamycin. Now, we didn't cure the disease, but we could double, triple survival. And as you alluded to, really knock down the inflammatory markers. So we'll come back to that. But I want to just because you started talking about the CSF1 inhibitors.
Right.
And how does that tie into the angry microglia?
Okay, so, it's sort of the life of the cell, right? You can talk about the life of the cell as going from the stem cell, M0, to the inflammatory cell, the M1, which is highly glycolytic, TOR1 dependent, right? It produces a lot of inflammatory cytokines, TNF alpha, IL-1 beta, probably nitric oxide, right? That's the M1 microglia. And then with further differentiation, it goes to the M2 microglia, which is fatty acid oxidation dependent, TORC2 dependent, right? And that's really the fully differentiated state for the microglia is the TORC2 differentiated microglia. And then you go eventually either die or you turn senescent, right? And what is almost certainly true is that when you use drugs like Rapa and you use drugs like ketamine, the brain distribution of the microglia changes. It changes from an inflammatory phenotype to a reparative phenotype. And then we're circling back to what we saw with elevated tau in our chronic pain patients, right? There's elevated TNF alpha in the CNS of these patients with chronic pain and with tau leaking into the bloodstream. And, the concept, what's going on is we having an excessive inflammatory response to tissue damage in the CNS. So, the clinical metaphor is gout, right? The immune system hates crystals, hates crystals, right? If you crystallize tau or you crystallize amyloid, the immune system's going to go crazy, right? If you happen to have an M1 microglia that's already highly inflammatory, you're going to get the hand grenade in the brain, and you're going to get premature nerve death and lots of stuff like that.
And the CSF1 receptor is specifically in these M1 microglia. Is that the idea?
I think so CSF is sort of like, one of these PI3, it's kind of like an insulin receptor, PSF, it's going to activate the stem cells to replicate. It's got a bone marrow in the brain, right? So it's going to activate your stem cell population to replicate.
Okay.
Right, but then you can't make it to the terminally differentiated state, which is
blocking that transition.
Yeah. There's you end up in an M1 state, and you can't make it to the M2.
Okay.
Because you've got so much TNF alpha and
do you remember the name of the drug?
Simon Johnson has it in his paper.
Yeah, I know. Is it pexidartinib?
Yeah, pexidartinib.
That's what I was.
I
think it's pexidartinib, but I wasn't.
Yeah, but you know that's going to be an expensive drug, and it's going to kill people, and there's no way.
No,
right?
I'm just trying to get a feel for where. So where are the different places you can block this process and get partial rescue in this mouse model? And so, I mean, I think you're right. I think RAPA, in many ways, is kind of downstream, right? It's blocking. It's not killing. It's not preventing the microglia from forming. It's not. It's presumably
high enough dose. I think you're going to get decreased microglia. Sure. Right.
Yes. Right.
But okay. So what does the Argentinian guys have? The Argentinian guys have this beautiful paper. I mean, it's lovely, 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 where they looked at monocytes that they took from depressed patients. Okay, and they were all abnormal. Okay, and they weren't abnormal in terms of serum levels. You know, the IL-6 and the CRP is all normal, but they looked at the monocytes from depressed patients, and they're like, these monocytes are not normal. They're too activated. They're in the M1 phase, right? And then they took these monocytes and they exposed them to RAPA, and what did they see? They saw massive increases, huge, of M2A macrophages, right? So it drives differentiation into a TORC2 state, which is highly phagocytic, highly reparative, right? We want our macrophages to eat every piece of bad tissue out there, right? And let the healthy mitochondria divide, right? And, let their DNA drive aging rather than the crappy mitochondria drive aging. Right. So massive increases in M2.
So let's try to see if we can, this will be very speculative, but kind of tie things together. So we know in a mouse model where we have this severe mitochondrial dysfunction, complex 1 deficiency, you definitely have a huge amount of brain inflammation, activated microglia.
Yep.
Blunting that multiple different ways has a beneficial effect on the disease, brain function, knock down inflammatory markers. We know with certain age-related disorders, brain disorders, you see a similar sort of symptomology in terms of activated microglia, lots of inflammation, and the same drugs, some evidence, are going to have benefits in that context. And I think some reason to believe that the underlying cause being mitochondrial dysfunction is driving the inflammatory processes in the context of these age-related diseases as well.
Right, certainly is part of it, right?
And inflammation is one of the hallmarks of aging, makes perfect sense. We also, what I think is interesting, see when you get outside of the brain, different cell types, but similar sorts of phenomena happening, right? With lots of mitochondrial damage, lots of inflammation.
Yes.
Angry macrophages invading tissues, presumably doing bad stuff.
Atherosclerosis, right? I mean, classic. A classic macrophage disease.
Right. So I'm just trying to draw the parallels between what's happening in the brain in this very early mouse model of mitochondrial disease and what we see in other tissues in other parts of the body with normal aging and also in the brain with normal aging. I think the one question I've got is certainly mitochondrial dysfunction can drive that anywhere.
Right.
To what extent in the context of normal aging is mitochondrial dysfunction the predominant cause of these inflammatory signals versus other things that we also know that keep, popping up as other ways to drive inflammation? And maybe it doesn't matter because the therapies can all act downstream of the inflammation, but I mean, obviously it matters, but I don't know the answer to that because there's lots of things. There's, gut barrier leakage and you start getting more microbial antigens floating around and maybe even infections in the brain. I don't know if we want to go into that, right?
Well, right.
DNA damage causing inflammation.
Right. Again, I'm trying to stop you before you get started, right? It's trivial as a biologist to show that everything isn't connected to each other, right? It's trivial, right?
Yeah,
the question
that's what I'm doing.
Is what are the large effect sizes?
Yes, which of these things are most important?
We can't optimize 10,000 genes. We just don't have the time, right? there's not it's the search problem that Google struggles with. We can't do everything. We have to pick what are our principal components. We all agree, right, that metabolic syndrome is a problem, right? It's looking like premature aging of the mitochondria in the presynaptic glutamatergic terminals is a problem, certainly for Alzheimer's, right? Lewy body disease is a little different. Parkinson's disease is a little different, but they're not that different.
Different cells maybe that are most affected, but mechanistically, yeah.
Yeah, mitochondrial quality control and Parkinson's disease, pink and Parkin. I mean, that's an entirely different mitochondrial control system, but it's mitochondrial.
Right.
Yep. So, but I want to get to this ketamine story.
Okay. All right.
So because it's important.
Okay.
So ketamine, in contrast, activates the M2C reparative microglia, right, which are related to modeling the extracellular matrix.
And when you say it activates them, so they already have to exist in order for ketamine to activate the M2C, or does it cause differentiation?
I think this is physical chemistry, just rate constants. There's an equilibrium distribution of M1s and M2As and M2Cs, and you can bias the equilibrium distribution, with using these drugs.
Okay, that's kind of what I was getting at.
Yeah,
so you think it actually affects the relative proportion of
the relative? There's always going to be signals for M1s and M2Cs and M2As, right? Because there's local signals that are going on all the time.
Okay,
right.
And I don't want to get too far in the weeds, but do we have a feel for how ketamine is doing this? Because I always go, right, what's the mechanism? Do we know a lot about that?
This is really interesting. And again, the people who are using ketamine are interested in ketamine. The quality of the information out there is really bad, right?
Yeah.
It's really bad, right? So there's an ovarian cancer model where they look at changes in glutamine signaling in the cancer cell, right? So the cancer cell can't become a cancer cell unless it's really good at using glutamine as an alternative fuel,
sure.
Right? Well, when it does that, it excretes high levels of N-acetyl aspartate into the surrounding medium, which hits the NMDA receptor on M1 macrophages and converts them into M2 macrophages. Right? So the whole issue of what's the signal that's driving the M1 and M2 distribution in the brain may actually be related to nitrogen signaling. Okay. Either glutamate, which everyone knows binds the NMDA receptor, but it may actually not be glutamate. It may be N-acetyl aspartate, because this is all very local signaling on a microscopic scale, on the scale of the synapse and the microglia contact, and we can't measure this with brain scans.
Right, which again, going back to everything being connected, right, it makes it hard to disentangle, but there's this whole enormous body of literature on mTOR and rapamycin affecting glutamine biology, and a lot of this comes from studies in yeast. I mean, the first paper where we showed that if you knock out mTOR complex 1 or knock down mTOR complex 1 in yeast, the mechanism we pointed to was the sort of glutamine shunt into the TCA cycle, right? Now that may be right or wrong.
Yes.
But I mean, it's all tied together.
Yes, nitrogen, not just fat and sugar, right?
Right. So, this is where it gets hard because,
remember, synapses are growing.
Yeah.
Right. I mean, again, we have all these pieces and we can't put them all together, right? Yeah. I mean, the tissue type that grows more than any other cell in the body is the brain.
Yeah, that's kind of wild to think about because nobody thinks about it that way.
Right. We're growing synapses at high rates with high nitrogen demand every minute of our life. Right. Unless you're working out really hard. Right. Yeah.
Okay. So back to ketamine. So it facilitates this M2 shifts the equilibrium.
It shifts the equilibrium to editing the extracellular matrix. So think about it. If we had just water in our head, every time we moved our head, we'd get a concussion, right? So we actually have a matrix, a gel, that holds the synapses in place And you can't grow a new synapse unless you digest some of the gel so that there's space for the new synapse to form, right? And there's this subtle interplay between eating a bad synapse and making enough room for a new synapse to form that is this beautiful biology that we know almost nothing about, right? And again, if you're doing artificial intelligence and you're training neural networks, you know how important it is to get this editing process right. And somehow biology has done it.
Right.
It's done it by training these microglia in the right way to know when a synapse is going to produce an AI hallucination, right? And now you can see as a psychiatrist why this is so important, right? We can't understand psychosis and schizophrenia unless we start thinking about these training modules that are related to nitrogen signaling. Isn't that fascinating?
Yeah. Yeah.
Yeah.
So most people who are listening to this will probably know of ketamine for, its addictive properties, use in ketamine clinics, Matthew Perry overdosing on ketamine, right? So how is that related to, or are those effects of ketamine related to this M2 equilibrium sort of
absolutely.
function?
Absolutely.
How are they related?
Absolutely. So, ketamine is the biggest advance in psychiatry in 20 years. No question. You talk to any practicing psychiatrist, they'll tell you this is the biggest advance. So the Lancet published a study that Harvard sponsored 400 people with treatment-resistant depression randomized to ECT versus ketamine. Okay. They'd already failed standard antidepressants. 55% response rate. Okay, that's at a fixed dose.
Wow.
We're not even talking about dose finding, right? Everyone knows in our business that there are these people that get remarkable responses to ketamine. My longest patient has been on ketamine for 18 years. Completely stable, fabulous responses. We don't have time to go over it, right? And is the concept related to their going off into the ether and seeing Jesus and Buddha? No, it has nothing to do with that. We're biologists, right? What's the mechanism of action? In the patients with chronic pain and the patients with chronic neuroinflammation, this sort of fatigue, brain fog, you'll see people get on ketamine and they'll just say, I don't know what happened. I feel healthy. And if you give rats high doses of ketamine, not low doses, high doses, you can see that they have improved N3 sleep, the deep restorative sleep that lasts for a week, after a single infusion, right? And the argument that I would make is you're seeing a phenotypic induction. You're driving an M1 microglia field into an M2C field, and you're literally digesting the scar.
Yeah, interesting.
The scar in the brain that's the piece of your experience. And everyone knows this, that PTSD, terrible disease, right, which we don't have good treatments for, randomized trials, 30% response rate in PTSD. Nothing works in PTSD, right? At the Seattle VA, they have an IV ketamine clinic, right? This is standard of care now, right? The drama about people using meds inappropriately, that's its own very long discussion about how do you help people find the right dose and the right provider, and
right.
This is a delivery system rather than
I agree.
biology.
Yeah. But mechanistically, you think that it's all tied into this M2 model, right?
Chronic daily dosing, the high dosing, I think is a very high probability it's going to be an anti-inflammatory effect, because I've seen it in my data and I've seen it in the Argentinian data, and certainly our combination treatment with rapamycin and ketamine in some individuals has really been life-changing. Just nothing has worked.
And let's talk about that, because I think this is something that is still not broadly talked about or thought about is this interaction between rapamycin and ketamine. Where does that come from?
This is going to get into the weeds really fast.
Let's do it.
Okay,
They're
so
fun weeds to
they're good.
wander
They're good
around
weeds. They're good weeds. Okay, so one of the things that scares me about rapamycin is if you look at the response of monocytes in culture when they're exposed to lipopolysaccharide, right, is they have a bimodal distribution of the excretion of TNF-alpha and IL-6 in response to RAPA. But low doses of RAPA, maybe the 1 milligram a day dose, maybe,
Sure.
right? You can actually see increases of inflammatory cytokines.
Right.
And it's not until you get to the higher doses that you see suppression of the M1 type. Okay. I saw that data and I was like, boy, that's really challenging. I wonder if we're going to see that in patients. And the answer is you do. Right? If you're not selecting healthy people that, I mean, all of this longevity stuff, they're screening for really healthy people generally. But when you go out into the clinic with people that are not in the center of the Gaussian, you'll see people that get pro-inflammatory responses to RAPA.
At what sorts of doses are we talking
Even
about?
1 milligram a day. I mean, you'll see painful mouth sores. They're not growth. They're an inflammatory mouth sore. They hurt too much. That's your clue clinically.
Okay.
You bite your tongue all the time. You go to the dentist all the time.
Yeah, I'm trying to wrap my head
hurts.
around the idea that the mouth sore side effects of rapamycin are inflammatory in
Do you know what you treat them with in transplants? Steroids. Oral steroid.
Okay.
I mean, I'm not saying it's true. I'm saying I suspect it's going to be true.
Yeah.
Okay. I've seen capillary leak syndrome at 1 milligram a day, which is, like, wow, what's that about? Right. So there's clearly going to be vulnerable people to the pro-inflammatory effect of RAPA. Okay. It's looking like it's release of PI3K gamma. Because if you use a pan PI3K inhibitor, you don't see the bimodal distribution.
This is in cells.
This is in cells, right? How do you go from cell to human? I mean, this is
right. That's
it's
why
a mess.
Yeah,
right. It's a mess. So I saw that and I was like, oh, that's really interesting, right? But if you're using ketamine, you can blunt that effect. So ketamine may be to some degree more proximal to PI3K gamma, because it's affecting, maybe the calcium flux in the dendritic, in the processes of the microglia. So it's more closely related to TORC2 than it is to TORC1. So in that case, they may be a really nice combination of, both of them inhibit M1. I mean, that seems to be very clear.
Mm-hmm.
Both of them are downregulating M1 expression in the central nervous system. And then you end up with this nasty problem, which is, what's the optimal distribution in the individual patient between the M2A and the M2C? And is this actually changing during sleep? Right? That actually you have to digest synapses and then switch quickly into M2C and digest synaptic matrix and then grow some new synapses while you're sleeping. I mean, this may be going on within the 90-minute sleep-wake cycle.
Yeah.
Right? I mean, the weeds get fast really quickly.
So what is your, I guess maybe one way to back up a little bit is at the patient level, what is your experience with the combination? What do you see or what have you seen when you've used ketamine plus rapamycin?
Well, I can give you some examples here. I mean, my longest patient on this combination, I'm trying to keep
and how do you decide who gets the combination as well? I think that's a really interesting.
Well, that's a discussion in its own right.
Sure.
I mean, because I'm learning crazy.
Yeah, of course.
Like crazy.
Of course.
I first prescribed ketamine 18 years ago, and I published in this in 2007. This was a kid who was sent to me by my partner who had autism. He was getting bigger, and they were going to give him up to the state because he was just too dangerous to have at home. And through various machinations, intellectual fantasies, I put him on ketamine, and that just stopped all the rage episodes. Just stopped it. Okay. And he was completely stable for 18 years. There's clearly a group of explosive individuals that ketamine eliminates this rage syndrome. And so I had this patient, I think, I don't remember exactly, who had gotten a partial response to IV ketamine. I had converted this patient to self-administered ketamine, still was doing better, but rages in the emergency room. I mean, it's really dangerous to have this degree of explosive rage, road rage, fist through walls, domestic violence, you name it, right? And I just, I get it. We got to see if we can add RAPA to make this work.
And there was at least one paper, right?
The Yale guys had shown that adding RAPA to ketamine increased the efficacy rate at 2 weeks after a single infusion from like 19% to 34%.
Okay.
Something like that. But I've been interested in RAPA before.
Right.
And so put this patient on RAPA and the combo, and it's just been like 5 years, gone.
And is this
gone?
Daily dosing?
Daily dosing.
Yeah.
I mean, a lifetime of explosive rage over 5 years, gone. Completely gone. I mean, it's just, you can't believe it, right? And then I've accumulated a whole group of people now that I've seen for years that get on this combo, and they are not the same, right? I mean, the classic, I think, is thermoregulation. I'll see people that their sweating is so bad that they'll start to even like think for an hour, and they sweat and they get too fatigued and they have to stop. And I have a person on the combination of ketamine and RAPA, and he's like, oh yeah, I was roofing in Arizona at noon. No problem. Like, that ain't placebo.
Yeah.
Right?
Yeah. Wow.
And I have a whole clinic of these people.
Yeah, this may be way off on a tangent, but is there any relationship to POTS? You know what POTS is?
Yeah, postural orthostatic hypotension.
Is there any relationship here? I mean, I know some of these the symptomology overlaps, right? Anxiety, depression, sweating sometimes. And so I'm just wondering, is there any?
I think what we're looking at is this is close. This is inaccurate. This is just what I'm thinking about lately. There's a population of embryonic cells that migrate from the yolk sac, okay? And they are mast cells, and they're closely related to sympathetic nervous system fibers. And in fact, this is well known. I mean, there's a tissue resident macrophage population that supports the sympathetic nerve cell fibers and edits them and keeps them healthy. And so when you have a defect in tissue repair, your sympathetic nervous system doesn't work very well.
Right.
And then you get this autonomic instability. Yeah. Everybody knows there's this triad of hypermobility, mild autism, orthostatic hypotension, chronic pain, or quad triad, however you want to call it. We see this all the time in the clinic, right? And people use this term mast cell disorder, which is, essentially a variant of it's a myeloid. It's very similar to the macrophage population. A little bit more optimized for Th2 worm and allergen autoimmunity rather than viral and cancer immunity. But that's probably related to tissue maintenance of the sympathetic nervous system. I have a lot of these patients. I just haven't had time to really parcel out my POTS people.
Yeah. I mean, again, obviously, it's more likely that it's not related than it is, maybe, but it does make me wonder if this sort of a therapeutic approach would have benefits in that population. Who knows?
I mean, we'll have data on this very soon. I mean, there's just too many people working in this area.
Yeah.
Right. I mean, the long COVID stuff is super interesting.
I think there's a really good chance that at least rapamycin, I don't know anything about ketamine in that context, but...
I already know. I mean, I know.
Yeah.
Because I've seen long COVID people respond.
To ketamine.
To RAPA.
To RAPA.
And to ketamine. But I mean, I have a guy right now who's in our multi-center trial with Cimarron, and I mean, he's one of these really data-driven guys. Does his own pulse oximetry, right? And he essentially reports an NDUF respiratory control disease, where if he flies up to 6,000 feet, he desaturates instantly. Big variations.
Interesting.
Big variations. And, the control function is oscillating really fast. And he was showing me his data. It's like, oh, yeah, when I'm on rapamycin and ketamine, it just goes away. And so I'm like, that's fantastic. Because it's not only used for COVID, it's all our opioid people. I mean, how are our...
Yeah, talk about that.
Well, I mean, that's 100,000 people a year dying from fentanyl, right? Why can't we get people off fentanyl? We can't get people off fentanyl partially because they have epigenetic imprinting of the microglia, right? They've been exposed to enough fentanyl long enough that their stem cell population in the brain is all M1. And you take away a central anti-inflammatory, which is opioids, and they get so sick that they can't make it. I mean, they really want to quit fentanyl. I mean, they're trying so hard to quit fentanyl. And I run an addiction. I'm the medical director of an addiction program in Snohomish County, and we treat hundreds of people with fentanyl withdrawal. And it's not that the patients don't want to get better. They're so sick when they get off fentanyl, and there's no support in the government agencies to take the kind of risks that we need to take.
Sure.
Right? I mean, we need to treat these people as if they have malignant cancer. And, do we need someone who's got a deep heart? I mean, I'm talking about some of your people, right? Who will help us randomize 10 people coming off fentanyl to placebo.
Yeah.
And 10 people coming off fentanyl to 3 milligrams of rapamycin a day. I mean, this is a study that should be done.
I agree. Yeah. And I mean, that's a small study. Like that is doable, right? I mean, it's not
we could do it tomorrow.
It's not a huge amount of
We don't need to go
resources
through
that we
IRB.
take. Yeah.
We go through Right to Try, Washington State. We could have data in a month.
And look, it might not work, but if your hypothesis is correct, there's a plausible biological mechanism whereby it might work.
These people they're gonna die. Yeah. 100%.
Yeah. Do you have any case examples? I mean, do we have a hint for rapamycin in this context?
The PA who's the CEO of this company that he's growing now has published with Lucinda Grand here in Olympia about using ketamine to help people transition from fentanyl to Suboxone. Okay. Now, it's not a randomized study.
Sure.
Right. And there's powerful placebo effects. Right. But sure looking that way. That we can do that if we add anti-inflammatories. And remember, this microglia population that is now epigenetically changed can last for months.
Right.
So you'll get people off heroin. You'll get people even off pain pills. Right? Everyone, get off oxycodone, get off morphine, right? And people say, hey, I'm off of it, and, maybe my overdose risk is lower, but I can't go to work. I'm so tired.
Yeah.
Right? And I'm not sleeping well.
Yeah.
That how can I possibly re-enter the workforce?
Right.
So there's this technical problem that's independent of aging, which is how do we target these folks with an anti-inflammatory? And again, just repetition for our listeners. This is nitrogen signaling. This isn't diet and exercise. Telling the fentanyl-dependent patient, oh, well, it's because you're eating crappy.
Sure.
Right. And you need to exercise more.
Sure. Right. Although, again, I think that's rarely bad advice, but that is not going to be curative in a situation like this.
Right. It's not the core. It's not the heart of the matter.
And maybe another way to frame it is if this idea is correct, which again, I think that's very plausible, a lot of arrows pointing in this direction, that the commonality between a lot of these conditions or syndromes is this microglial sort of defect, and there may be different types of defects, but that's sort of a common cause.
Right.
A general anti-inflammatory isn't going to do the job unless it does the job on the microglia. I mean,
Right.
I think that's the disconnect, right? So
Yes.
you can't just go take an NSAID and expect it to fix the problem.
No.
Right? So that's where I think this term anti-inflammatory is so general that it doesn't really capture the nuance that's important here. You need something that is going to specifically have the anti-inflammatory effect where it's needed, on the cells that it's needed, and maybe in some cases even affect this distribution within the microglial
Right.
population.
And again, it's the female, and there's the important sex differences, right? Which is, the males may have more of a TNF alpha mediated immune tissue repair function in the context of dominance battles and predation, whereas women are more of the interferon IL-1 beta immune system. And I think we just saw that in the preprint from the aging guys doing they saw this great response to RAPA in women.
Oh, the Pearl trial.
The Pearl trial, right? But they didn't see anything in men. Right.
Yeah. Again, I don't want to speculate too much about why that's the case.
No, I get it. Right. But
it's an arrow going in the.
But we
direction.
have to remember gender differences too.
Sure.
Right.
Yeah.
I mean, there's our heads are going to blow up every day. I mean, it's humiliating.
Yeah. Yeah. No, it's not. It's fun. So I mean, I think this idea though of opioid withdrawal and a new sort of way to tackle that is really important. And clearly this is a, immense problem in society right now.
Huge.
And so if there's any way that we can start to get a handle on that, that, could be a game changer. And so hopefully this conversation can at least, spur some more thought and maybe some opportunities to actually do something about that.
I think there's two pieces I want to put out there.
Okay, go for it.
Number one, it's just how important that we, as biologists, partner with the AI guys.
Mm-hmm.
Okay, biology is too complicated, and we need the capital from Silicon Valley and Microsoft to help us design tools so we can reduce this complexity. What we're doing isn't working, right? We're in these silos where it's rheumatology, it's pulmonology, it's not working. We all know it's not working, right? And we need to have people that have a different skill set than you and I to help us compress this data in ways that we're not overwhelmed with the complexity. And I've tried to recruit people for a long time. I can't get them. I'm a solo practitioner. I mean, I'm not in a position to do this.
Yeah.
But we're not going to make progress until we do this. I'm certain of that. We can't. It's too incremental. You and I have talked about this.
Yeah.
We're going to take these tall, tiny steps until we can do data compression. Okay. I think the second issue is just regulatory reform. Right. I mean, when Elon Musk says, look, it takes me more time to fill out paperwork for every time I make a Starship change than it does for me to change the project, that's a problem.
Yeah.
Okay. You talked about when you were working at the university, 80% of what you did was paperwork. Okay. More and more of my bandwidth is related to credentialing, quality control, than it is to using lithium to save people from Alzheimer's like today.
Yeah.
Right. Or using rapamycin to help women with chronic pain today. Right. I think politics flies downhill from culture. And somehow, and I don't know how to do this, we need to develop a local network here in Washington State. Not in the feds are done. They're too big, they're done. But I think you and I in Washington State and other people need to develop a local network where there's a legislative fix, where the legislature says, we want Washington State and Microsoft and Matt Kaberlein and Jon Berner and whoever else is in the area to have as much flexibility as we possibly can do to invent new tools for our people, right? And they passed right to try, which is great, right? But we need more.
So what would that look like?
I think we have to get the trial lawyers people in the room and the medical board people in the room and think about the concept, instead of setting up guidelines related to this is good practice or this isn't good practice, talk more about just basic contract law. Are you delivering what you promised? You're going back to talking about source code, right? What's happened is we started with this source code of like, oh, we have this product, medicine, and it needs regulation to make sure it's honest. And the bureaucracy has grown and grown and grown, and now the bureaucracy has become a self-licking ice cream cone.
Yeah. I mean, I think, we need certainly we need basic protections for
It's all
people.
contract law.
Right.
It's people come to me as a provider in Snohomish County, right? And in King County, and they say, I need an hour of your time. Give me the best advice relative to what you see is at the moment.
Right.
And, you can't regulate this. There's too much complexity. Every time you add a regulation, it slows the process down.
Yeah.
It has to be more of like, are you simply doing what you say you're doing? Are you really doing a longevity program at OptiSpam? Are you really publishing? It's just simple stuff. And you leave it to the market to come up with the credentialing rather than assuming that, because again, I'm so sorry, but like the Washington State Supreme Court recently expanded liability for psychiatrists, saying that civil law, the contract law, essentially means that psychiatrists are responsible for predicting when someone's going to predict a violent event. Okay, so I looked at this decision and I just burst out laughing.
Yeah.
Because it was divorced from reality.
Yeah, I mean, I think that's the problem, right? Is when the policy and legal position really does not consider at all the impact in the real world, right? I mean, it sounds to me like, I'm not familiar with the specific decision, but it sounds to me like yet another decision that is really only going to have the impact of making medical professionals, psychiatrists, less likely to actually take action to do something to help their patients because they're scared of getting sued, right?
Right. And again, everybody means well. I mean, I don't think there's bad actors here.
Yeah.
Right. But it flows downstream from culture.
Yeah.
Right. And the culture needs to be, I think, is the people in Washington State need to say, look, we have this amazing company, Microsoft, which is a well-run company. Right. And we need to turn Washington State into a biomedical research hub. And the way we do that is we set up a system that encourages innovation, that we set up our standards to encourage new ideas.
Yeah.
Rather than just be fearful. I mean, like this idea that California is going to regulate AI
I think
is
the
crazy.
Fear
is crazy.
Yeah, is the big driver here, right? And
Right.
and in many ways, I think the general public is being conditioned to fear all sorts of stuff that they don't need to be afraid of, but the consequence is that stifles innovation, right? Unfortunately,
but your people, the people watching this podcast, right? They get it.
Yeah, I think so.
They get it, right? They get it. Like, it's not hard to write a letter to say, hey, I've got early Alzheimer's. I want my physician to do whatever is possible
Right.
to save my life, right?
Yeah,
That's not a
but then
hard
you're
argument
fighting
to make.
against the medical boards and the people who manage the licensing and all of that.
It's a good fight.
It is a good fight.
It's
I
a good
agree.
fight. It's the kind of fight that no one in the bureaucracy are bad people. Okay, I don't see them as malignant people, right? They're responding to their incentive structures. And the way to change it is not to put a fix on the bureaucracy, but to change the incentive structure
Yes.
from a legislative perspective, cultural perspective first, and a legislative perspective later, saying, no, we want Washington State to be like Venice in the Renaissance, right? Like, and we want your company, OptiSpan, we want open road, we want green lights every way down the road, because what you're doing is so important. We couldn't regulate you even if we wanted to.
Yeah. I'm not sure what the right answer is there, to be honest with you. I mean, I think the challenge with removing the regulation altogether is that there are people who will take advantage and be dishonest and do stuff that's really sketchy. And so we need I don't know what the right balance is. We need some way to encourage innovation and inform consumers, clients, patients.
Right, we go old school. What was the old school way? I live the old school way.
I don't know what the
No,
old
but
school
I live
way
old
was.
school, right?
Yeah.
My number one credentialing is the reputation that I have for 25 years in the local community.
Sure.
Right?
And yet people will buy into people who have no credentialing. I mean, just look at the whole internet influencer culture. People listen to just nonsense from people with no expertise at all and just eat it up. So I think this is where, when we get to medicine, I don't know if the average person can be trusted to make an informed decision.
Yeah, I mean, again, to me, this is profoundly paternalistic.
Yeah.
In the sense that I don't know a dang thing about how to design a chip, right? I don't know a dang thing about whether the food that I'm eating at my grocery store, has E. coli because somebody didn't wash it right. Right. What we've done is we've set up, I think, this false dichotomy that if we don't have a complicated level of regulation, that the market isn't going to develop an alternative way of credentialing. And I think that's an error.
Yeah, I hear
I think
you.
that's an intellectual error.
I can't believe I'm arguing on the side of regulation, because I tend to be pretty much, a libertarian when it comes to a lot of this stuff. But I guess the question would be, how many people have to die before that?
They're already dying.
Well, this is true.
This is the invisible. This is the invisible graveyard, right? Right. I think you and I have somewhat of a strong belief system that if we had enough courage, without being influenced by the area, that with a combination of lithium and rapamycin and metformin, that we could radically lower death rates. We think more likely than not that's true.
Yeah.
Okay. Is that going to happen in the next 10 years? No, because we're enmeshed with this Gulliver's Travel.
Yeah. Certainly not at scale. There will be the people who
right. There are the and again, it's highly unethical.
Yeah.
Right.
Yeah.
The rich people that are smart in downtown Seattle are going to get access to OptiSpan.
Yeah.
Okay. My fentanyl addicts who are despised, what are their chances of getting RAPA?
Yeah.
0. There's a certain very uncomfortable inequality with this.
Yeah, no, that you're absolutely right. And I think this is the...
you can make all the regulation you want. I'm still rich and well-connected. I'm going to get my drugs. Right. But who isn't going to get the drugs? The middle class, the poor, the uneducated.
Yeah.
I mean, we in psychiatry have dealt with this for years. If you've got schizophrenia or drug addiction, you just forget about getting expensive cancer treatments.
So I agree completely. I think, couple things that one of the things that we are really focused on is how can we scale as much of this as possible within the current framework? Because I agree with you. I think if the regulatory framework changed, there would be real opportunities to bring a higher level of care to a lot more people. I don't see that happening in the short term for sure.
No.
So how do we scale what we can do for as many people as we can? And I think there are opportunities. And I think this is where, even though it may sound naive, I do believe that the AI tools really have some promise for, they're not going to get rid of healthcare disparities, but having an impact there, because
Huge.
a lot
Huge.
can be done much more efficiently.
Yep.
So I balance between pessimism and optimism. But I think on the regulatory side, I mean, it'll be interesting to see where it goes. I think, you talk a lot about Washington State. Montana is kind of interesting. So you probably haven't been paying attention to any of this because it hasn't gotten much bandwidth. But, Montana passed an expanded right to try law.
Right.
There's a really, I think, interesting state senator there named Bogner, who sponsored that. I think there is an appetite in some places for this sort of, regulatory sandbox where new things can be tried. I don't know if Washington is going to get there because there are complicated political considerations in Washington, but I think there may be opportunities for this in places. I would love to see it happen here, where you can actually enhance informed patient access to some of these things. It's still not going to be quick, but there are opportunities to actually move the needle a little bit.
Again, without reiterating too much, I have the opportunity to see people who work for Facebook and Amazon and Boeing. Microsoft is a really well-run company. People are happy there. I think there's a nucleus of people that are really independent of the state government, that if they really wanted to make this happen, they could make it happen. I'm a little bit more encouraged than that.
We'll see what happens. Maybe they're listening.
Yeah, I hope so.
Awesome. Well, this has been super fun. We covered a lot of ground. I think we said some provocative things, which is always good.
Right?
Yeah. No, I think it's important, and really appreciate you sharing your thoughts and experience with us. Thanks so much for coming down today.
Thank you so much for having me.
Awesome. And thanks, guys, for watching the OptiSpan podcast. As always, please leave your questions or comments below. If you're not yet a subscriber, you know what to do. And I hope to see you next time on the podcast.